The topic of this talk is liver transplantation. Why, when, and how. Part 1. I have no financial disclosures relating to the topic being discussed in this lecture. So, why do we do liver transplantation? To save lives. Now, what does that mean? Why would it sound almost flippant? I think what we're trying to say here is that liver transplantation, the main goal is for it to be a life-saving procedure. In most cases, liver transplantation allows for patients to have a better quality of life. However, that cannot be guaranteed because many of the things that we need to do, such as a very large operation, the post-operative medications that patients have to take where they develop more medical problems, may not necessarily allow them to lead a medication-free life. And in that case, the indications for liver transplantations are not always necessarily to just improve the quality of life, but rather to save lives. And so if a patient comes to you and wants to have a liver transplant because they feel fatigued, that in general is not considered an indication for liver transplantation. The major indications for liver transplantation are decompensated cirrhosis, unresectable primary hepatic malignancies, and acute liver failure. So to review, decompensated cirrhosis. This is probably the most common indication that we give for people to have liver transplantation. However, just because a patient is cirrhotic doesn't necessarily mean that they're ready to be worked up for liver transplantation. You need to realize that the survival of a patient with cirrhosis changes when they decompensate. And decompensation is defined as someone who has had a complication such as variceal bleeding, ascites, and hepatic encephalopathy. In this article, you can see that patients who have decompensated have a significantly lower survival at 1 year, and therefore, in the presence of decompensation, a liver transplantation workup needs to be thought of. In this slide, you can see that survival is dramatically decreased in patients with refractory ascites or hepatorenal syndrome. Both of these can decrease survival dramatically, as you can see, at the 1 year base to such low numbers as less than 20% in patients with type 1 hepatorenal syndrome who develop rapid onset of acute renal failure due to this syndrome. Patients with refractory ascites have very low survivals, well below 70%. So when should we think about doing a liver transplantation in someone with liver disease? As mentioned before in looking at the survival curves, as you can see, the time to do liver transplantation is when there's evidence for poor prognostic factors associated with liver disease. So patients who have had complications of cirrhosis, such as ascites, hepatic encephalopathy, or variceal bleed, should be referred for liver transplantation workup. Other signs of poor prognosis are development of hepatorenal syndrome and spontaneous bacterial peritonitis, as well as evidence for poor synthetic function. There are also some special indications for liver transplantation. As mentioned in our prior statement, primary hepatic malignancies such as hepatocellular carcinoma is a special indication for liver transplantation. And in these patients, in order for the liver transplantation to occur, they must fall below the Milan criteria. The Milan criteria defines patients who have hepatocellular carcinoma with 1 lesion less than 5 centimeters or 3 lesions less than 3 centimeters. These are patients who can qualify for liver transplantation under the right circumstances, and that is because if you exceed Milan criteria, there is a high rate of recurrence. A second special indication, as noted before, as one of the common causes for having a liver transplantation is acute liver failure. Patients who present with acute liver failure as manifested by a high INR and rising sudden onset of liver failure should be considered for liver transplantation, and in fact should probably be transferred to a center which can handle rapid workup for liver transplantation. Other special considerations are metabolic diseases such as familial amyloidosis, where the trigger for the disease is in the liver and thus replacing the liver may actually cure the disease. Other more unusual complications are things such as primary sclerosing cholangitis, where patients may be listed for liver transplantation if they have recurrent cholangitis. Other unusual causes for liver transplantation are patients with polycystic liver disease. And these patients may have very good liver synthetic function but have very large cysts which preclude them from having a normal life. Another very unusual indication for liver transplantation are patients who develop hepatopulmonary syndrome. These patients have a window in which they can be transplanted and have a reversible outcome to their pulmonary disease related to their cirrhosis. So in addition to patients having poor prognostic signs, another measure in which you can determine if somebody needs a liver transplantation is by trying to look at parameters which predict outcome. In early days, we used something called the Child-Turcotte-Pugh score. And as you can see in this table, this score was calculated by the presence of encephalopathy, ascites, bilirubin, and albumin. And as you can see, you can either get 1, 2, or 3 points depending on the severity of these manifestations. And therefore, based on adding these numbers up, you can get a Child-Turcotte-Pugh score of 6 to 10, and in that way divide patients who have more stable liver disease as a child A cirrhotic as a patient who has more severe liver disease as a child C cirrhotic. Historically, the Child-Turcotte-Pugh score was used to predict survival from abdominal surgery and shunting, and then subsequently it was used as a criteria to determine how people who were listed for liver transplantation should be allocated livers. However, this has now been surpassed by the MELD score. The MELD score, which is the model for end-stage liver disease, can be calculated by a combination of a bilirubin and an INR and creatinine. The MELD score is a very complicated equation, and it's difficult to calculate in your head. And so often people go on the internet to use a MELD calculator to calculate the MELD. And the MELD range is from 60 to 40. This was a way in which we could determine what the 3 months for mortality was from liver disease. And this has now been adopted by the UNOS, which is United Network of Organ Sharing, as a way to determine how sick a patient was, and therefore the patient who is the sickest would get the next liver. As you can see on this slide, the MELD score is actually a very good predictor of 3-month survival on the liver transplant list. Patients with a MELD score of less than 10 actually had an almost 100% survival at 3 months, as opposed to someone who has a MELD of greater than 40 has really a less than 20% survival. And so this was a very good way to determine who on the list had the sickest disease in regards to their liver. In the past, patients were listed for liver transplantation had both parameters to determine who was going to get the next liver. The first parameter was how long they waited, and the second parameter was how sick they were. The new criteria for determining who was going to get the next liver is purely on who is the sickest, and therefore the patient with the highest MELD score gets the next liver. How are liver transplantations done? The standard liver transplantation is that of an orthotopic liver transplantation. An orthotopic liver transplantation merely means that the liver is placed in the same location as the native liver, and therefore the native liver is removed and the donor liver is placed in its location. Liver transplantation occurs through a multiple anastomosis, including the vena cava anastomosis, the biliary anastomosis, portal vein anastomosis, and hepatic artery anastomosis. Liver transplantation is very successful, and patient survival, as you can see on this slide, is well over 80% at 1 year. Showing the survival benefit of patients with liver transplantation. One thing to keep in mind is that 1 year survival at 80% is wonderful for someone who has a much less 3-month survival. For instance, someone who has a MELD of 30 would have a survival that was far below this 1 year survival of 80%. However, this is why you don't do liver transplantations for just symptomatic relief of your liver disease. It is because although we have an 80% survival, that implies that up to 20% of patients can die in that first year after liver transplantation. And therefore, it is important to recognize that liver transplantation improves survival, but your survival without a liver transplantation must be worse than that in order to justify a transplant. In this slide, you can see with the 80% survival in 1 year that this far exceeds a patient who has decompensated cirrhosis, and therefore, in the right patient, liver transplantation is certainly warranted. The reason that we don't transplant everybody is because we recognize that in order for the transplantation to be successful, not only do you have to go through a major operation, but subsequently, in order to prevent rejection, you most likely will need to be on a calcineurin inhibitor. And a calcineurin inhibitor is cyclosporin or tacrolimus, being the most common ones that we use, are associated with some significant side effects, including high blood pressure, new-onset diabetes, headache, and most commonly renal dysfunction. All of these create an additional problem post-transplant, and also makes one recognize the importance of compliance. These are not medications that can be taken lightly, and patients need to show a certain level of compliance in order for their transplant to work. In addition to cyclosporin and tacrolimus, in the first year, patient will also be on steroids and mycophenolate. And as you can see here, the long list of side effects, that these are not drugs which are easy to take. And so, in essence, in order to get the 80% survival, you need to select patients who are able to take these medications in a timely manner, as these are not drugs that do not have significant side effects, and therefore the ability to take these medications in the way that it's prescribed is extremely important, illustrating the importance of the psychosocial evaluation of a liver transplantation. This slide demonstrates to you that in the long term, in order for patients to survive with a liver transplantation, it is associated with certain comorbidities. And in this slide, which shows what are the common reasons that patients have graft failure, you can see that a very common reason is recurrent disease. And recurrent disease are things like hepatitis C, for which the patient was transplanted pre-transplant. It does not go away once you've been transplanted. Other things such as cardiovascular disease represent a large cause of morbidity after liver transplantation, and these need to be kept in mind as one makes the decision of whether or not a transplant would benefit their patient. In addition to the need for compliance and need to understand that you can develop new diseases after liver transplantation as a result of the immunosuppressives, one also needs to recognize that there are just not enough organs in the United States. In this slide, these are the number of transplants that have been performed in the last 20 years. And as you can see, we have now plateaued out in terms of the number of transplantations. And yet you can see that the number of patients waiting for a liver transplant in September 2nd, 2011 is 16,987. This far exceeds the number of patients that can be transplanted every year. And therefore, as a society, we recognize that there are significantly more patients who need liver transplants than the number of organs that we have. We want to save as many lives as possible, but we also need to recognize that it needs to be cost-effective and have the best outcome post-transplant. Sometimes this is very difficult for patients to understand, because even if you had a 20% survival with a liver transplantation, if it were you would want to have the transplant. But from a societal standpoint, it may not be reasonable to give a scarce resource such as a liver transplant to somebody who only has a 20% survival when there are patients who could have an 80% chance of surviving with a transplant. Given that option, society would choose to give the liver to someone who has an 80% survival rather than 20%. And while these are very difficult questions that transplant centers and transplant committees must make, they are ones that are made on a daily basis. From an individual standpoint, as a physician, one needs to also evaluate the patient very carefully to see if they can individually benefit from a liver transplant. And that is when you come up with your best guess of what your patient's survival would be with and without transplants. For example, these would include things like medical evaluation. If your patient has cancer from another source, giving them a transplant may not prolong their survival and yet take an organ away from someone who needs it. Other things are cardiopulmonary evaluation. This is very important, as this is a very, very large operation and involves someone who has very good cardiopulmonary function in order to survive in a reasonable fashion. The psychosocial evaluation is also extraordinarily important, and these are mostly the ability to comply to complex medical instructions, social support, and also substance abuse. Patients with liver disease often do have a history of substance abuse, and it is important to recognize this and evaluate this closely to make sure that the risk of recidivism is low. It is important to recognize that when each patient you need to assess the risk and benefit of transplantation. There are also some contraindications to transplantation, and that, as mentioned before, includes things such as non-hepatocellular carcinoma cancer other than simple skin cancer, which can recur in the light of heavy immunosuppression, advanced HIV, or severe behavioral disease or social conditions that would prevent patients from following complex medical instructions. In order to make this kind of decision, there is generally in every transplant center a selection committee, generally composed of hepatologists, surgeons, social workers, and coordinators, who then get input from perhaps cardiology, radiology, and general medical, as well as other subspecialists, and through a committee make a decision as to whether to list the patient, defer, or reject. In the VA, a similar process occurs, but there are some slight modifications. The liver transplant package, which consists of all the testing that you would require to make these difficult decisions, such as your cardiopulmonary evaluation, dental, mammogram, multiple lists of evaluation are done in the local VA. The package is then sent to the national office and reviewed by the Liver Transplant Board. A decision is made by the national office as to whether patients should go to the next step of being sent to one of the VA liver transplant centers where patients are evaluated in person, and the decision is finally made as to whether to list the patient, defer, or reject. So in summary, Liver transplantation is a life-saving procedure for patients with acute and chronic liver disease, but the selection of appropriate patients is critical. This involves determining the risk and benefit for each patient. The MELD score is a good predictor for short-term survival in patients with cirrhosis and is used for the allocation of organs in liver transplantation. Thank you.